Hello students, good day to all of you. This is Dr. BK for you, and today's topic is I am going to speak on the hard and the soft palate. Now, with respect to the oral cavity, in the last class I have discussed about the features of the oral cavity, that is the subdivision such as the oral cavity proper and then the vestibule of the mouth. Then we have discussed in detail about the features of the tongue, that is the presenting parts, muscles, vessels, nerves and lymphatic drainage. Now, in this class, we are actually going to learn about the palate. So, mainly a short introduction about the palate, where actually it is situated and what are the main subdivisions. So, you have the hard or the bony palate. So what are the bones forming and what are its lining membrane. Then followed by that, we will be discussing in detail about the soft palate. So its presenting parts, composition, then the muscles of the soft palate, which mainly comprise the soft palate, and then the nerve supply, blood supply, and finally the clinical aspects. Now, first coming to the palate, as I told you, it is made up of the hard or bony palate, anterior 2/3, and posterior 1/3 is mainly made up of soft palate. Now, where actually the palate is situated? It is situated between the nasal cavity and the oral cavity. So, it forms the roof of the nasal cavity and floor of the oral cavity. Okay, so somewhat like a partition between the nasal and the oral cavity. Okay, now so the anterior 2/3 and the posterior 1/3, both the bony and the soft palate are actually covered by the mucous membrane on both the surfaces. That is the lower surface or the inferior surface as well as the superior surface. Okay, now while the anterior part or the bony palate is mainly made up of bones, the posterior part is actually made up of muscles. Okay, 5 pairs of muscles comprise the soft palate. Okay, and as I told you, both are covered by the mucous membrane, and both the hard and soft palate have mucous glands, so which secrete the mucus. And apart from that, in the soft palate you also have taste buds. Okay, and not only that, the palate, as we see in this diagram, is not straight but it is arched. Now here you are able to see the roof of the mouth with the mucous membrane. It is actually arched from before backwards, and it is also arched side to side. Now why actually this arching is necessary? To mainly accommodate the tongue, so that the tongue can freely move during your mastication, okay, speech, and also during the deglutition. Okay, so that is how you are able to see the palate, which is contained within the alveolar arches, but it is arched from before backwards as well as to side to side. So this arched pattern of the palate is mainly seen in the humans. Okay, so as I told you, mainly the soft palate possesses the taste buds, and mainly the bitter taste is actually recognized by the soft palate and also on the wall of the pharynx. So now coming to the hard palate or bony palate, which you are able to see here, mainly you come across this in the norma basalis of the skull. So the hard palate is also contained within the alveolar arches of the maxillary bone. So it is mainly made up of two bones, So here you are able to see this is actually mainly the palatine process of maxilla. These two bones are actually the palatine process of maxilla, and this is your horizontal plate of palatine bone. Okay, so that is the palatine process of maxilla, and the other bone which you are able to see is the horizontal plate of palatine bone. Okay, so these two palatine process of maxilla, there is a suture in between which is called as the intermaxillary suture, and between the palatine bone what you have is the interpalatine suture, and between these two sets of process you have the palatomaxillary suture. Okay, so these 1, 2 and these 3 sutures together form the cruciform suture. Okay, so now if you look the mucoperiosteum, because it is covered by the mucous membrane as I told you, and deep to the mucous membrane mainly you come across the mucous glands in the hard palate, especially on the posterior surface. These palatine glands on the posterior part of the hard palate, these palatine glands are actually much concentrated. Then the mucoperiosteum shows a midline raphe, a line extending, which is called as the midline raphe, and from that raphe what happens, you can see the numerous transverse fold extending. Then the oral surface of the mucous membrane is lined by stratified squamous non-keratinized epithelium, whereas the nasal surface, the mucous membrane is lined by the ciliated columnar epithelium. Okay, so that is the lining epithelium of the hard palate. Now, the other features, as I told you, in the midline, you see a median fibrous raphe, so extending in the midline. And anteriorly, here you have the incisive fossa. So, there you see this mucus also forms a papilla. Then, from the either side of the midline, you can see numerous folds, mucus folds extending from the fibrous raphe or transverse fold. Again, this is concentrated more on the or nearer to the anterior part of the hard palate rather than to the posterior part. So these folds, transverse folds, give the oral surface of the hard palate a corrugated appearance. Okay, so it gives the hard palate the corrugated appearance. And as I told you, it is contained within the alveolar arch and arched from side to side and also from before backwards. Now, in children, it is slightly at a higher level, that is one vertebra above, at the level of the atlas vertebra in case of the children. But in adults, what happens is it is present at the level of the axis vertebra. So that is about the hard palate. So mainly you should know about the bones forming the hard palate. Okay, that is the palatine process of the maxilla and the horizontal plate of palatine bone. Okay, so next coming to the soft palate. So the soft palate mainly forms the posterior 1/3 of the whole palate, and definitely it is attached to the posterior border of the hard palate. Now, while the hard palate, I told you it is a bony palate, the soft palate is actually a fibromusculoglandular structure. So, mainly it is made up of the fiber or aponeurosis. Then you have 5 pairs of muscles, and then it is actually covered by mucous membrane, and deep to the mucous membrane also you have palatine glands. So that is why it is a fibromusculoglandular structures. Now, it also extends downwards and backwards between the oropharynx and the nasopharynx. The main function is deglutition. So when swallowing the food or the process of deglutition, so this soft palate will get tensed, elevated, and it will close the communication between the oropharynx and the nasopharynx. So this posterior to the nasal cavity, what you see is the nasopharynx. Posterior to the oral cavity, what you see is the oropharynx. So there is a communication between the nasopharynx and the oropharynx. Okay. So when we actually breathe, the nasopharynx conducts only the air, whereas the oropharynx conducts the food and air. So the communication between the nasopharynx and oropharynx is actually called as the pharyngeal isthmus or nasopharyngeal isthmus. Okay, so this communication will be shut off when you are swallowing. So the soft palate, what happens, will get tensed, and it will actually, when it is stretched and then it is elevated, this communication is shut off by the soft palate. So thereby what happens, the food swallowed in the second stage of deglutition will have to actually pass downwards into the from the oropharynx to the laryngopharynx. So it does not accidentally pass above into the nasopharynx. Regurgitation of food does not takes place. Okay, so that is why when the palate contracts, what happens, it closes the pharyngeal isthmus, or it is also called as the nasopharyngeal isthmus. So when actually this closes, as I told you, during swallowing, and when you want to blow your air from the mouth. So when you blow your air from the mouth also, the palate get stretched and contracted. So now let us also discuss about the other features of the soft palate. What are the presenting parts? So when the soft palate is at rest, it is pendulous or something like a curtain which hangs downwards. And you can see it is roughly quadrilateral in shape, which has actually got a inferior surface, or you can call it as a anterior surface and a posterior surface. Then it has got a inferior and a superior border and two lateral borders. So these are the borders and surfaces. So two surfaces are the, what you are seeing on the oral aspect is the anterior surface, and the other one is the posterior surface. The anterior surface extends downwards, okay, and forwards, and this also presents a midline raphe, which is actually the raphe which is continuing from the hard palate, the same midline raphe. Now this, when the palate is tensed or stretched, this surface becomes the inferior surface. The anterior surface, when it is stretched, becomes the inferior surface. Next, see the posterior surface. Now, well, this surface is actually concave anteriorly, whereas the posterior surface is convex. So, you saw the concave's anterior surface. The posterior surface is actually convex, and when the palate is stretched, this will actually become somewhat superior. Not exactly it is superior. It won't become a very, what do you call, exactly like a horizontal line, but it slopes to some extent to actually go and close this pharyngeal isthmus. So anterior surface, and then what you see is the posterior surface. Okay. Then next we will actually pass on to the, now you are able to see the palate when it is tensed. So this becomes the inferior surface, and that becomes somewhat superior surface, not exactly like a transverse line. And the palate is closed not only during deglutition or speech, but when also you want to blow air through the mouth. So now coming to the borders. So the upper border, is attached to the hard palate, posterior free sharp border of the hard palate called as the palatine crust. Okay, it is attached to the hard palate. The lower border again shows which is free, and in the midline you see a conical extension which is called as the uvula. And from this lower border, two folds extend. The anterior one is actually called as the palatoglossal fold. It passes in front of the fossa for the palatine tonsil. So it passes in front of the tonsillar fossa. And the posterior border, there is a posterior fold which is called as the palatopharyngeal fold, which extends posterior to the palatine fossa. So from the lower border, you see two folds extend. One is the palatoglossal arch and other one is the palatopharyngeal arch. They are mucous folds, and deep to these folds you have the muscle of the same name, Palatoglossus and the Palatopharyngeus Muscle. Okay. So next, coming to the composition of the palate. So the palate, especially the soft palate, is mainly made up of Palatine Aponeurosis and 5 pairs of muscles, and then you have palatine vessels and nerves, and then you have palatine glands. All this is actually covered by the mucous membrane. Sometimes if the palatine tonsil also extends into this surface. So now coming to the first, the framework of the soft palate is mainly formed by this palatine aponeurosis. Okay, so mainly formed by the palatine aponeurosis. So this palatine aponeurosis is mainly formed by the expanded tendon of the Tensor Velay Palati muscle. Okay, so this is actually this muscle. You are able to see the Tensor Velay Palati muscle. So this tendon passes around the pterygoid hamulus and then it expands. Expansion of the tendon is actually called as the aponeurosis, and it is attached to the posterior part of the hard palate or the palatine crust, to the posterior margin, free margin of the hard palate. So it forms the fibrous framework because the other muscles, 4 muscles, will insert or originate, especially the Levator, Velay, Palatini inserts, and the other 3 muscles, the Palatoglossus, the Palatopharyngeus, and the musculus uvulae muscle, they actually take origin from the palatine aponeurosis. So anteriorly to the posterior margin and the palatine crust, and in the midline, actually it splits to enclose the musculus uvulae. Okay, so if you trace it laterally, it is continuous with the tendon of the Levator, the Tensor Velay Palati muscle. So muscles of the soft palate, as I told you, each half of the palate has got 5 muscles. So totally in the palate there are 5 pairs of muscles. So to name them, they are actually the Tensor Velay Palati, Levator Velay Palatini, and then you have the Palatoglossus, Palatopharyngeus, and the musculus uvulae. So we will actually try to understand the origin, insertion, action, and nerve supply of these 5 muscles one by one. So first muscle which we are going to discuss is the Tensor Velay Palati muscle. So as I told you, the tendon of this muscle forms the fibrous framework. Now, here you are able to see the Tensor Velay Palati muscle. It mainly arises from the scaphoid fossa of the medial pterygoid plate. So here you are able to see the medial pterygoid plate, and there you are able to see the lateral pterygoid plate. We just trace the origin of the medial pterygoid plate. It encloses a small fossa near towards the root, and that is called as the scaphoid fossa. And apart from the scaphoid fossa, it also arises from this is your auditory tube. from the lateral wall of the or lateral lamina of the auditory tube. So it arises from the lateral lamina of the auditory tube. Okay, so then it also arises from the sulcus tubae. So this tube is actually present in a sulcus, which is between the petrous part of the temporal bone and the sphenoid bone. So it also originates from the sulcus tubae, from the lateral wall, and also from the sulcus tubae, and also from the spine of sphenoid. This is your foramen ovale, this is foramen spinosum, and behind that you see the spine of sphenoid. So that is the origin of the tensor veli palatini muscle, lateral lamina, and also from the undersurface of the petrous temporal, that is the sulcus tubae, spine of sphenoid, and lateral lamina of the auditory tube. The fibers actually pass downwards and they wind around the pterygoid hamulus. Okay, so they wind around the pterygoid hamulus. There, actually, the tendon of the tensor veli palati is also separated by a bursa. Otherwise, if there is no bursa, then the tendon will always there will always a friction be created between the tendon and the pterygoid hamulus. Okay, so the fibers, they converge to form a rounded tendon around the pterygoid hamulus, and then they expands to get inserted as the palatine aponeurosis into the hard palate, posterior border, and to the palatine crust. Okay, so the main function is actually it stretches the soft palate. Okay, so mainly it stretches the soft palate, and it also depresses the soft palate. So during its action, since it is attached to the lateral lamina, it also dilates the auditory tube. Okay, so that is why it is also called as the dilator tubae. So it also dilates the auditory tube in addition to stretching or tensing the soft palate. That is about the tensor veli palatini muscle, this muscle which you are able to see here. The next muscle which we are actually going to discuss is the levator veli palatini muscle. So the levator veli palatini muscle arises from the apex of petrous temporal. So on the undersurface of the apex of petrous temporal, and it is getting inserted into the upper part of the palatine aponeurosis. So mainly it arises from the petrous temporal in front of the carotid canal, and also from the lamina of the auditory tube. Okay, so mainly it arises from the medial lamina of the auditory tube. Then what happens? It passes downwards and medially through the sinus of Morgagni. So this is the lateral wall of the pharynx. So between the base of skull and the upper border of the pharynx, there will be a small space which will be covered only by the mucous membrane, and then the pharyngobasilar fascia, not the mucous membrane, but the pharyngobasilar membrane or fascia. So don't worry about that. We will discuss that in the pharynx class. So through that, the levator veli palatini will pass, and it will get inserted into the upper surface of the soft palate, that is to the palatine aponeurosis, in between the two fasciculus of the palatopharyngeus muscle, that is the anterior and posterior fasciculus of the palatopharyngeus muscle. So mainly it elevates the palate and closes the pharyngeal isthmus. So I told you what is pharyngeal isthmus already. Okay, so here you are able to see the levator veli palatini muscle. So it arises mainly from the apex of petrous temporal bone, on the undersurface of the apex of petrous temporal bone, and also from the lamina of the auditory tube. Okay, and the fibers actually pass through the sinus of Morgagni. Okay, it passes through the between the skull and here the upper part of the constrictor muscle. So upper border of the pharynx, they will be actually just closed by a membrane. So the auditory tube, levator veli palatini, ascending palatine artery all passes through that space. Okay, so levator veli palatini and the auditory tube passes through the sinus of Morgagni and gets inserted into the upper surface of the palatine aponeurosis. in between the anterior and posterior fasciculus of the Palatopharyngeus muscle. Okay, so it mainly elevates the palate. So next muscle is the musculus uvulae, which you are able to see here, origin from the posterior nasal spine and from the hard palate. So actually it is originating from the posterior nasal spine and also from the Palatine Aponeurosis. The muscle fibers, they pass downwards and get inserted into this conical projection, that is mainly to the base of the uvula. Okay, so it inserts into the base of the uvula, the mucosa, deep to the mucosa, submucosa. So the main action is it pulls the uvula to the same side. So right musculus uvulae acts, the uvula moves to the right side, and same way to the left muscle acts, it actually moves to the left side. Okay, so here you are able to see this muscle is actually the Levator Velay Palatini muscle. So that is your hard palate and that is your soft palate covered by the mucous membrane. So this is your Levator Velay Palatini attaching to the upper surface of the hard palate. More laterally, what you see is the Tensor Velay Palatini muscle. So moving on to the next muscle which we are actually going to discuss is the Palatopharyngeus muscle. So it actually originates from the Palatine Aponeurosis as two fasciculi, anterior fasciculi and the posterior fasciculi. In between the two fasciculus means it is actually bundle of muscle fibers. Okay, so in between the two fasciculus, what you see is the Levator Velay Palatini muscle. Okay, so the anterior fasciculi usually arises from the anteriorly in front of the insertion of the Levator Velay Palatini from the upper surface, whereas the posterior fasciculi mainly arises from the lower surface of the Palatine Aponeurosis. Now both the fasciculi, they actually unite and it passes deep to the mucous port, that is the Palatoglossal arch, which forms the posterior boundary of the palatine tonsil. This is not palatine tonsil, this is actually your posterior 1/3 of the tongue. Mainly it is filled with the lymphoid follicles, the lingual tonsil. But here you are able to see a small projection here, that is actually the palatine tonsil. So it forms the posterior boundary of the tonsillar fossa. And the fibers, actually what happens, it joins with other two muscles, mainly from the auditory tube one fiber, that is the Salpingopharyngeus muscle, and other one from the styloid process you will get one more muscle which enter into the pharynx, that is the Stylopharyngeus muscle. So the fibers unite with the Salpingopharyngeus, Palatopharyngeus and Stylopharyngeus, and finally they are getting inserted into the posterior border of lamina of the thyroid cartilage. Okay, so they get inserted into the posterior border of the lamina of thyroid cartilage. So when these muscles contract, the thyroid cartilage, that means your larynx will be elevated. So it helps in elevation of the larynx as well as the pharynx. Thereby it closes the larynx during deglutition. So even though these three muscles are actually longitudinal muscles of the pharynx, they mainly help in elevation of the larynx and thereby they will close this inlet, the laryngeal inlet. Okay, thereby the bolus of food passes only to the laryngopharynx, to the esophagus. It does not enter into the cavity of the larynx. Okay, so that is the one of the main function of the palatopharyngeus muscle combined with the salpingopharyngeus and the stylopharyngeus. Some of the fibers actually are inserted into the lateral wall of the pharynx, through which they reach again the fibrous raphe of the pharynx. So midline raphe, it is not fibrous, the midline raphe of the pharynx to the lateral wall of the pharynx into the pharyngeal raphe. Then some fibers, what happens is they pass backwards. Okay, some of the fibers. So here you are able to see the palatopharyngeus along with the salpingopharyngeus and the stylopharyngeus getting inserted to the posterior lamina of the thyroid cartilage. So when actually this pulls, the muscle contracts, then naturally what happens is the the larynx will be elevated. Same way pharynx will also be elevated. Okay, now some fibers, I told you it is the lateral wall goes to the midline raphe. Some fibers they form a U-shaped sling. They will actually form a U-shaped sling continuous to the fibers of the opposite side, and they will raise a fold which is called as the passavans ridge. So passes under cover of the mucous fold, the passavans ridge in the posterior wall of the pharynx, and they form the sphincter. Okay, so they mainly form the sphincter, so which is responsible for closing, the nasopharyngeal isthmus. So some fibers they pass backwards and form a sling-like structure with the fibers of the opposite side. So this will pull the fold of pharynx forwards when the palate is also elevated. Okay, that is actually called as the passavans ridge. So I will come to that the next slide. So that is about the palatopharyngeus muscle. So next we will actually move to the palatoglossus muscle. The next muscle is the last muscle of the soft palate is the palatoglossal muscle. So origin from the inferior surface of the palatine aponeurosis or soft palate, then passes under cover of the palatoglossal arch, and what happens is, so it is actually passing deep to the palatoglossal arch. Here you are able to see the muscle fibers, palatoglossal arch, and then what happens is getting inserted into the sides of the tongue, and the palatoglossal arch passes in front of the tonsillar fossa. So the palatoglossal arch passes in front of the tonsillar fossa and inserts into the side of the tongue. So mainly it is the muscle of the tongue rather than the soft palate. It elevates the posterior part of the tongue or the base of the tongue and closes the oropharyngeal isthmus. So this is the oropharyngeal isthmus, which is the communication between the oral cavity and the pharynx. So it is bounded below by the tongue, on either side by the palatoglossal arch, and above by the soft palate. So when deglutition takes place, the base of the tongue will be elevated, and these two palatoglossal arch will actually be approximated, and the palate will get tensed. So whereby the oral cavity is completely shut off from the oropharynx, which is behind. Okay, so that is how what happens is the oropharyngeal isthmus is closed. Now you know how the nasopharyngeal isthmus is closed, the communication between the nasopharynx and the oropharynx. So that by what happens is the bolus of food which is actually swallowed should not again come back into the oral cavity. Same way, that is why it is closing the oropharyngeal isthmus. It should not go above into the nasopharynx. That is why it is closing the nasopharyngeal isthmus, and it should not go into the larynx. So that is why the larynx is elevated and closing the laryngeal inlet. It has to only pass into the pharynx, laryngopharynx, and then into the esophagus. So now you would have understood the main function of the soft palate, which is the deglutition. So that should be the primary function of the soft palate, and also preventing regurgitation. Okay. So next we will come to the passavans ridge. Before that, this palatoglossal arch is also called as the anterior pillar of Fossus. Whereas behind the palatine tonsil, you see the palatopharyngeal arch, that is called as the posterior pillar of Fossus. One is the anterior pillar of Fossus, and another one is the posterior pillar of Fossus. Now let's actually come to the passavans ridge. So as I told you, the palatopharyngeus muscle gets attached to the lateral wall of the pharynx and also into the lamina of the thyroid cartilage. Certain fibers, as I told you, they sweep backwards into the posterior wall of the pharynx. Same with this half of the palate will have the same muscle. They will also sweep backwards and attaches to the pharynx. So they form a U-shaped muscular sling. So when the palate is actually tensed through the tensor Velay palatini, it is stretched. It will also raise a fold on the posterior wall of pharynx to approximate the soft palate, and that is called as the passavant's ridge. Okay, so now we will actually try to see here, that is the passavant's ridge. Okay, so next, coming to the mainly the soft palate is also, you are able to see the meeting point of three muscular slings. Okay, so the three muscular slings are above the muscular sling formed by the Levator Velay Palatini. So they form a sling, U-shaped sling above. Okay, then the next sling, what you see is below, it is formed by the Palatoglossous Muscle. Okay, so the other sling is the Palatoglossous Muscle, which actually closes the oral cavity from the oropharynx, Oropharyngeal Isthmus. So that is the Palatoglossous Muscle, which forms a sling below. A sling above is the, what you see is the Levator Velay Palatini. And one more sling posteriorly is the, as I told you, the Palatopharyngeus Muscle, which forms the passavant's ridge. Okay, now the place where the soft palate touches the passavant's ridge, it is also the place where there is a mucus transition. Okay, so I will come to the mucous membrane. Now, the lining membrane on either side, whether it is the inferior surface or the superior surface, it is the mucous membrane, and it is lined by the stratified squamous non-keratinized epithelium, that is the inferior surface, and also the posterior part of the superior or the posterior surface. Only the upper part of the posterior surface is lined by the ciliated columnar epithelium. So the place where the ciliated columnar epithelium gets transitioned into the stratified squamous epithelium is the place where the soft palate will touch the passavant's ridge. Okay, so the change in epithelium corresponds to the passavant's ridge of the pharynx. So it is this place where it touches. So the whole of the anterior or the surface is covered by the stratified squamous non-keratinized, and also the part of the posterior surface. Only the anterior part of the posterior surface will be lined by the ciliated columnar epithelium. So this is how your stratified squamous non-keratinized epithelium will look like. So superior part, you will have the squamous cells, flat cells. Then middle part, actually you have polyhedral cells, and lower part you have low columnar to cuboidal cells. So different layers, many layers, so that is why it is stratified, and superior layer is squamous, so that is why it is called as squamous. If you have a keratin deposition, then actually you come across mainly in the skin. So based on the thickness of this, you call it as the thick skin or the thin skin. So now coming to the blood supply of the soft palate. So mainly it is supplied by the greater palatine and the lesser palatine artery, which are the branches of the maxillary artery. So the third part of maxillary artery we have discussed in detail. Through the greater and lesser palatine foramen it enters, and then it supplies the greater and lesser palatine artery. They are also anastomosing with the sphenopalatine artery, which passes through the incisive canal. Okay, so mainly it is the greater palatine artery. Then other branches which is actually supplying is the ascending pharyngeal artery, that also gives a palatine branches to the soft palate. Then also from the facial artery you have ascending palatine branches. So ascending palatine branches. So facial artery will give ascending palatine branches. It will also give tonsillar artery, the principal artery to the tonsil. All this is given by the facial artery in the neck before entering the face. So ascending palatine branch of facial artery, then palatine branch of ascending pharyngeal artery. Apart from the greater palatine artery is the blood supply of the palate. Okay, then veins actually drain into the pharyngeal plexus via the paratonsillar veins, and lymphatics mainly into the retropharyngeal nodes, and from there it goes to the upper cervical nodes. Okay, so next coming to the nerve supply. So 5 pairs of muscles are there in the soft palate. So the motor muscles, nerve supply to the muscles motor is by the pharyngeal plexus, which mainly through the motor component of the pharyngeal plexus is the cranial part of accessory nerve, which supplies all the muscles of the pharynx except the Tensor Velay Palatini muscle, which is supplied by the trunk of the mandibular nerve, branch from the trunk of the mandibular nerve, Tensor Velay Palatini along with the Tensor tympani. Okay, so apart from that, your Palatopharyngeus, Palatoglossus Musculus, uvulae and Levator Velay Palatini is actually supplied by the cranial part of accessory nerve, which is a component of the pharyngeal plexus. The pharyngeal plexus will have a motor component, it will have a parasympathetic and sympathetic component and also a sensory component. Okay, so we will discuss all that in the pharynx. So mainly that is the motor nerve supply. Coming to the, I have already told you, palate consists of lot of palatine glands, so it should have a secretomotor or parasympathetic supply. It is mainly from the pterygopalatine ganglion, and the postganglionic fibers pass through the greater and lesser palatine nerve and supply the glands of the hard and the soft palate. So again, pterygopalatine ganglion we have discussed in detail. It actually arises from the lacrimatory nucleus of the pons, passes to the facial nerve, geniculate ganglion, greater petrosal nerve, nerve of pterygoid canal, relays in the ganglion. Postganglionic fibers for the palate reaches via the greater and lesser palatine nerves. So that is the parasympathetic. Apart from that, I told you sensations. It has two types of senses. One is the general sensations, mainly through greater and lesser palatine nerve. Then you have the sphenopalatine nerve and also the glossopharyngeal nerve. Okay, taste sensations. Okay, so that is the glossopharyngeal nerve which you are able to see here, which also carries the taste sensations to the soft palate, oral surface. The fibers which are also carrying the sensations to the posterior 1/3 of the tongue. Now, taste sensations also pass through the lesser palatine nerve also. So through this they will reach the facial nerve. From there they might go to the nucleus of tractus solitarius, that is concerned with the complete taste sensations. So general sensation is by greater palatine, lesser palatine, and mainly your sphenopalatine and glossopharyngeal, that is the 9th cranial nerve. Okay, and the taste sensation is mainly by the also by the glossopharyngeal and also by the lesser palatine nerve. So next, coming to the clinical aspects, mainly in children, what happens after the diphtheria attack, sometimes the palate muscles might go for paralysis. In such children, what happens, the oropharyngeal isthmus will not get closed during deglutition, and there might be a, what do you call, the regurgitation of the food, and the voice is also mainly nasal voice. Okay, so it mainly you have a nasal voice during speaking. Then this is a very common thing which affects one of the congenital anomaly is the cleft palate. So it might be a complete cleft palate or a partial cleft palate, and sometimes it is also affected with the cleft lip. So here you are able to see the palate. Okay, so the palate is mainly made up of two sources. The premaxilla forms the primary palate, which is from the frontonasal process, and the postmaxilla is by the maxilla, palatine shelves. Now, if there is any degree of non-union, so here you are able to see the anterior part of the palate accompanied with a cleft lip. So here only the posterior part, soft palate actually. This is posterior cleft deformity. This is anterior cleft deformity. This is complete cleft palate. The whole palate is completely cleaved and associated with the cleft lip, that too bilaterally. So this is very severe or 4th degree of the cleft palate. Okay, so that is all for the palate today. And thank you very much for your patient listening.